Megan, I'm going to go ahead and we are recording now. So the topic of this is health scores, and this is somewhat of a continuation of our conversations last week on our health scoring system with Humantive, our future plans with the health score, and what that can mean for patients and for physicians. So we'll go ahead and start with talking about our current health score. And Nabil, I'm going to ask you if you want to start adding in, I guess, where you're at in terms of the health score, what we have now and how that's calculated. And then I'll start talking about future plans and what else we plan on tying in. But if you want to go ahead and take it now and explain what we currently have, go ahead.
Yeah, so I mean, the score we have right now is very simplistic, but kind of good at giving a general idea on people's activity. So it only takes into account your step count, your activity time, and your sleep. And what it does is basically, we know what, through knowledge or through studies, we know what's the good kind of range. So when you are in that range, you get 100% of the points. And if you're outside from the healthy range to the maximum range that a human can do, actually, for steps, for example, from 0 to we're using the 10,000 step number. From 0 to 10,000, it's a linear progression from 0 to 100 points. So basically, if you stay in the healthy zone, you're always going to have 100%. Deviating from that, you start getting your score kind of go down and up, and your total score is an accumulation of your daily score. So every day, if you're being healthy every day, you'll obviously have the maximum, the score 100%. If one day you're not as active, it's going to impact with just a little weight. So it's not really going to impact a lot. So we are looking at other ways of making this a little bit more personalized. For example, we know that everybody cannot exercise a certain time, or cannot do a little or number of steps. So depending on their handicap or other diseases they have. So that's what's coming, and we're actually looking at personalizing everything. Also at bringing some other metrics, heart rate. We're looking at blood pressure and some other things that can give a general idea of the health of the person. But the idea is basically to have every day a summary of your health, and have that accumulates every day, so that if you're unhealthy or recovering from something, from a disease, or you can't be healthy those a few number of days, it should not impact a lot on your health, but it will actually impact a little bit. So that's where we are right now.
Yeah, I think we're making really good progress in terms of just visualizing what you're doing on a daily basis, your activity, the amount of sleep you have, and your heart rate, your resting heart rate, which I'm a big advocate for, is lowering your resting heart rate. And there was this one Fitbit article, or a study that Fitbit released, that showed the data that corresponded with lower heart rate, and then just it drew some conclusions in terms of just the healthiness of populations based on their resting heart rate. And that was a very eye-opening study. Did anybody get a chance to see that? Remember that? I need to find that again, because I saw that just somewhere on Twitter. I never saw it again. While I'm thinking about that, let me find that. Well, can somebody find that?
Can I comment on that just for a minute? So I did sign up for your beta test. I'm enjoying that. I hooked up my Fitbit to it, and I looked at the links to HGraph and the links you sent me. And I think that for the preliminary, I really have a good feel for it, and I've been using it, and I understand it's a little bit klutzy still. I think that the three things you're measuring right now, steps, activity, and sleep, those would go on any physician's list to health. okay, for just about anyone. Activity and steps together actually combine a lot because they tell you a lot about overall function. And sleep obviously affects huge things. So sleep apnea, poor sleep, good sleep. Heart rate for healthy people, for people that have good underlying health, for that subset that are runners or athletes, you know, I would agree that it can be a useful parameter for fitness. But for, you know, someone who's seen 100,000 patients, we really don't think, oh, this person, as a matter of fact, if we see a heart rate of 50 in someone over 50, we're getting an EKG looking for a heart block if they have any symptoms. So I don't think that heart rate is not something that most physicians would attribute with health from a long-term perspective. Acute, it's one of the first vital signs I look at. But whether someone has an 80 or a 60 or a 70, doesn't factor into health. It factors into fitness, which I think is what you're referring to. And one of the things is sometimes when you have these young internet folks who are healthy and in their 20s, like the HGraph people and the Go Invo people, and I saw their founders and everyone's in their 20s. I think that from the health score perspective, I think moving from a 30 to 35 in a 60 or 70-year-old patient with diabetes is a huge, huge thing that would be very valuable to physicians. We're moving a healthy you from an 80 to an 85, probably not too concerned with that. So I think the value from a quality of life perspective for the unhealthy people is in the lower numbers. Does that make sense? So that's just a quick take. I won't talk anymore, but hopefully that gives you some insight into that.
No, that makes a whole lot of sense. And also I want to kind of go down that road a little further. You as a physician, let's just do a hypothetical. If there was an app that you could prescribe to your patients and it tracked certain metrics like what we're doing now with steps, with your active minutes throughout the day, your sleep, and there were other data points that you could put in there that you could track, maybe your weight, blood pressure. It would need to be personal based on the patient's condition, I'm sure. But what would be your ideal health score? The parameters in there and all the different inputs. I'm sure you probably have something in mind.
Well, I looked at that. I've only just looked at the HGraph things. So I looked at that, and I know, is that the software you guys are working from, the open source HGraph software? Is that part of what you're using?
Yes.
And actually, intuitively, I felt good with nearly that entire graph. Okay, and I think most doctors would feel comfortable. If I was advising HGraph, I would say the one thing they don't have is they don't have a good indication of things like stress and depression. And I think that mental health and its association with physical health is underrepresented. So yeah, glucose is important, other things is important, sleep is important, but I think the HGraph only had, quote, happiness, which is difficult to measure. So I think I would have maybe something, quiet time. I was just fooling around with ideas like quiet time or meditation time or no TV time or no social media time, which can be meaningful to people with stress and anxiety. Someone who tried to commit suicide 3 months ago might have a pretty high score, and they're not healthy, because they're borderline suicidal. So I would think through the mental things longer term. And that can be helpful to manage patients. But if I saw an HGraph, if I had a download of an HGraph, it's so intuitive. I was actually pretty impressed. I think I commented on something called spark lines, which are also very intuitive, what you guys are using for tracking data with those little gray barriers. I ran across that concept a year ago, and I've been looking for it, and you guys were the first times I saw it. So anyway, for the beta test, I like the 3 parameters: sleep, activity, and steps. pretty much would tell me that person's got some mobility. That would work for, I think, a wide range group and be helpful information.
I think the next two that we're going to be measuring, of course, we're doing everything that can be measured automatically. Just sensors that you don't have to manually input the data. You can just take a blood pressure, Bluetooth blood pressure cuff, have that reading automatically synced up with the app, your wireless scales, stuff that can be just done automatically. You won't really have to think about it. So the next two would be your weight and your blood pressure as well. And there's other different devices out there that you can start importing that data. But I think we need to go one or two at a time. And with HGraph, if you saw some of those screenshots, everything is included. And that's the overall idea. That's the objective, is to go there and look at all the determinants of health and how that factors into a personal health score. And I mean, I'm looking at some screenshots here, and you have your family history of Alzheimer's and dementia, and all your blood counts and just vaccinations, and all that is factored into this health score. And I'm right there with you, Matthew. The spark lines or band lines, whatever you want to call that, I think that might be some overlap there. But it's an easy way to take in and visualize a lot of information, because sometimes you just have an information overload. And it's kind of like that action paralysis thing where you just don't know what to do with it. It's just so much data, you can't really find any insight into it. And I love the visualization aspect that Involution Studios really takes hold of. And everything they do is amazing, by the way. I'll put out a plug for them too. Chromebook and Involution Studios. They do some great work in terms of health data visualization. And I don't know if you read some other stuff about their ideas of the sensors in the bathroom. They're really interesting. And pretty much everything that they have had a vision for, I would like to start incorporating into what we're doing. Of course, they believe in open source movements as we as well. So there's a lot of synergy there. But adding to these health scores, I was talking, John and I and Megan, we talked to Bradley Hennefert last week, and they have him and a group of 3 other doctors. They put together a treatment score system that pairs up perfectly with what we're doing. So their treatment score system, it was for physicians, and it allowed them to prescribe the best treatment based on that patient's desire or their health. And from what I gathered, it was almost a probability rating of this treatment has this probability of being effective, and kind of go on down the list. And it's based on price. It's based on what type of outcome you want. And it was amazing. It's a great idea. And I know, Matthew, you mentioned something about it, kind of a wish list for an AHR. It was not necessarily the diagnostic tool, because you can get a lot of the diagnosis correct, but it's the treatment side. What's the best treatment at this given time for this patient? Which is going to work best? And that's something they're working out. And after we discussed a little bit, it's a perfect pairing for what we have, because you have this personalized health score, and now with the algorithms that they have, you can even get more of a precise treatment score or treatment suggestion. And I really wish he was here on this conversation here. But Matthew, you may have heard about him on Twitter. I'm going to share his website with you. Let's see.
So Matthew, another challenge that we're having with the app is that we have 2 different things. We have to calculate the health score, but we have to also reward for that health score. And so we are trying to separate those 2 things, because, I mean, people can, anything that's manually input can lead to cheating. And anything that's automatic is more trusted. So that's why we have heart rate right now, but it's not included into the generation of Medit. So being healthy right now does not mean having good heart rate does not mean you're getting Medit, but it actually impacts your health score. So, and there's a lot of challenges. Like one of them, for example, is you were talking about it, is personalizing this for somebody, like you said, who has mental issues. Just doing a little bit maybe is actually needs to be rewarded needs to increase their health score comparing to somebody who's already runs ultra marathons and just, did 5,000 or 10,000 steps. It's really interesting to personalize and have those journeys. I don't know if you signed the app. There's like 4 different journeys right now,
yes,
but we can
make
them. We can add more to them. But I think the journey is where we should have specific cases, maybe generic cases where some of them maybe would need, or we can add to some of them manual input for your stress, for how much your mood, how are you feeling today, etc. But for others who are more competitive and needs more minutes, we'll probably just have automatically input data. And then the other challenges is, to me, I don't believe that we need to have a very precise score, because we just cannot get it, and some users won't have all the data needed for that. Some people probably have a Fitbit that does not have heart rate. They don't have, they can't input their blood pressure, or they can input it once every 6 months when they go see a doctor, while some other people can do it every day. So how do you give to those different users that, how do you use the same score for all of them? So it seems to me like what we should move forward is something more, I would say, qualitative than quantitative. So like the quality, like to try to extract from the data some information instead of just putting everything into algorithms and saying, well, this is how things should be because of this equation. Trends, for example, are very important. If you're doing good every day, it doesn't matter how much you're increasing, but you're increasing. It's better than going stable with 10,000 steps. If you're going 2,000, 3,000, I think the person who's going slowly up deserves more credit than somebody who's just stagnant at a really high bar.
That was one of my notes I made, was that the meta score is in the change. For a lot of people, it's in the improvement rather than absolute amount. And,
exactly. And then the idea also is to get kind of complete the feedback loop, which is, I'm doing good, my score is increasing, I'm more motivated to do more. So how to get that thing going and going and going, in circles?
It's almost like we need 2 scores. You have this one comprehensive health score that gives you an accurate insight into where your health is in corresponding with where you're at, your age, your demographic, with everybody else too. Are you unhealthy? Not necessarily just how is your health score. Are you an unhealthy individual? How bad is your health score? And also that secondary health score, the one that you can gamify, that you can try to improve daily, weekly, have different metrics, but may have that one comprehensive health score that you can really bet on in terms of a physician looking at that saying, okay, you need to increase this, and this. We've talked about that before. There's multiple health scores. One that, I guess, go back to that one that can be gamified easily, and one that is an accurate representation of a person's health over time. If that makes any sense.
That was my question, actually, for Matthew. As a physician, because I'm far from a physician, but when you're looking at a patient, you're kind of taking a baseline when you first see them, right? And then from there, you're looking at their improvements overall, and that's how I would take the health scores. You're taking a baseline of who it is, and as Nabil was saying, you actually reward them as they improve. I'm not sure. Have you guys ever played around with the Samsung Health app at all? Anyone here?
Yes.
Samsung Health actually has quite a few of those ideas of stress, and actually measures it. Now the accuracy of it I won't speak to because I don't know how accurate it is, because supposedly the pulse ox on there is good, the heartbeat and everything else, but there are ways to input your stress levels at the time it's taking your heart rate, so you can actually tell all that information there. I don't know if that's something that's useful. Again, back to you, Matthew, if that's considered helpful in your case, or are you looking, if a patient brought this to you, would seeing a baseline in their improvement be more informative to you in that case?
Well, I think that for I think that it depends what type of doctor I was. All right. So most of my experience has been in urgent care, which is more acute care, though I have board certifications in primary care. I think a cardiologist would be most interested in the change because these people are unhealthy. He's dealing from an unhealthy population. So they're going to be very interested in a guy who's 30 moving up to a 35 and then a 37 and using that as a tool to encourage them and say, well, this is what you're doing. It's great that you're walking every day. It's great. Whereas if you were a orthopedist, fitness guy, then things like heart rate and other things come into play. Then you're more concerned with the absolute numbers and maybe so it probably depends on what type of physician you are, where you'd find the value. I brought this up 2 weeks ago, and I think that the obesity medicine doctors, it's a new specialty. There's 2,000 of them. Obesity is deeply involved with a lot of the things you're discussing: sleep apnea, steps, activity, diet, and it's probably 80 or 90% driven by behavior outside of the doctor's office, and it's about behavior change. And if I was just saying, if there was a market to penetrate those 2,000 or 3,000 physicians that are trying to come up with new tools to help with out-office behavior, that would be, I think, a natural choice. Because then you really just do need steps, and then you do need activity, and you do need sleep. You don't need anything fancy. You don't need glucose. You don't need a lot of those other parameters. So you have those 4 journeys. And the journeys, this is just an aside. When I went through the app on the journeys, it's nice to know that it's changeable right up front. So it's not a forever journey that you pick, and then you can change your journey later. But I figure that's things you're going to get to all that stuff as time goes on. There needs to be a weight loss journey on there, because 50% of the United States wants to lose weight. Whether they should or shouldn't is a different issue. But that's what January 1st they're all thinking about. I think the only thing they're thinking more about is saving money. So there needs to be some type of journey for that, which I think that would get. And if physicians said, boy, this actually helps people lose weight, because nothing we have out there really does, except for surgery. But there's not a lot of tools out there which all doctors use all the time that works, with the exception of surgery. So obesity, weight loss, those 2,000 or 3,000 specialists, they have like 4 or 5 conferences a year that they attend. And if you could get one of the thought leaders in that space to talk to you, I'm obviously not one. I have a certification on paper, but if you can get one of those people from Harvard, or there's a couple other people, I could maybe send you some names. If you could talk to them about behavior and your ideas, they would have a lot of insight into that. I'll keep my eyes out for a couple names you could reach out to.
Yeah, I appreciate that. I'm looking at the list of events. They also have webinars. But yeah, two a month webinars for the Obesity Medical Association.
That's one of them. The other one, probably the biggest, is one based out of Harvard once a year, and that's probably the top of the line event. And then there's an Obesity Week in Washington D.C., which is more of a lot of the vendors will be there for that, and that'll be a different type of thing. So that's just something to keep an eye on if you are looking for a specialist. Thought leader in that space would have a lot of insight. 2-hour talk with him or her would probably be a big deal.
Yeah, we'll definitely do that, because that's, like you said, 50% are obese. That sounds like a low number to me, based where I'm at. That's a very low number.
Yeah, so you're in Mississippi.
Yeah,
it might be number 1 or 2. So
it's I tell you, I went to this was in Louisiana. Now kind of bordered up with on the line. I went to a fair last year, and I promise you, y'all, it was out of, I don't know, hundreds of people I saw, there were 2 people, well, 3 that were fit. the rest were very obese. And I'm not exaggerating either. It was me and one other guy and my wife, and that was it. And I'm sitting here looking around thinking, this is bad, because then you see their children are obese, and you're noticing there's going to be a cycle there. These habits already ingrained of how they eat and their habits. Well, that generation is going to grow up. What's it going to look like 20, 30 years down the road? And how bad is it going to be? And that's one thing.
Actually, it's even something called epigenetic. So if the mother is overweight or underweight during pregnancy, then the child is more predisposed to being overweight. So it's not just genetic or behavioral; it's actually in the womb, in the fetus.
Yeah,
it's a multi-generational problem.
I think a lot of it, from what I see too, is also just choices, personal choices. What do you put in that buggy? You're checking out.
Do you on your is it not? Is it Nabi? Nabi? Is that
Nabil?
Nabil, sorry.
Nabil, yeah, no problem.
Do you use BMI in your health score?
We don't right now.
Okay.
But I think it's something that we should use, especially if we include the weight loss journey.
We have a few months to gear up for that. So January 1st, we'll plan on that front and center, that journey. Because if you look at all the apps in the App Store, the top ones, it seemed to always be around losing weight, diets, different motivational apps for working out. So digital apps for health are big, but it seems like nothing is doing what we're doing. It's all, here's a different type of routine at the gym type thing. Here's a diet. It's not necessarily tying in behavioral economics into it, taking data from all these different sources to really give a person a view in their health and nudge them in the right direction, which is part of these journeys. Whatever your journey is, we're going to nudge you in that direction based on other things we have coming out, the different types of meal plans that we have planned coming out, and different types of workout plans and motivational stuff there. So it's a work in progress, but I do think just having the immediate feedback in terms of you earn something for your activity is a huge motivational tool that has been proven to work a lot. But there's a few studies in there that pay people to walk, and as long as they're paying them to walk, they walk. But the only problem was once they stopped paying them, they stopped walking. It wasn't a behavioral change. It was just a very temporary change. So it's one benefit we do have with cryptocurrency is never before in history have we had a chance to create a new form of currency. And
that would be the medics. And on the medics, you want that to be highly documentable data, like Fitbit data that's imported, not necessarily things you can't fake, so to speak. That's kind of key to that part of your business model.
Yeah, that's MEDIT, though, MEDIT.
I'm sorry, MEDIT.
MEDIX is our security token, and that represents equity in citizen health. And that gives voting rights, different staking mechanisms. But yeah, that's why we want things that can't be cheated, because if you do have that open-ended, how many steps did you walk today? How much sleep did you get? And you could input that. Well, you could easily cheat the system. That's why we want the data coming from devices that we can trust, that we do know that you didn't cheat the system. I mean, you can cheat the Fitbit a little bit, but those people, we'll come up with ways to circumvent that. But so the idea is to create a new form of currency that is generated by a person's pursuit of health. So you are generating value based on what you do throughout the course of a day and a week and a month, and that implies value to that currency that you do generate. And by being healthier, you generate that currency, which can be used to offset healthcare costs or to outright purchase products and services that are only focused on health and wellness, not a bag of Cheetos somewhere, but to start facilitating these positive feedback loops where you can get a discount on your gym membership, which should cause you to have more active minutes throughout the day. It should cause you to lose weight and lower your blood pressure. Therefore, you earn more MEDIT, and it's just a positive feedback loop versus the negative feedback loops that we have in place now with just reactive side of medicine.
So for some of the rewards, have you guys, since I know obviously, preventative medicine shows, I believe increased patient compliance and all that other stuff and better outcomes. Have you guys thought of like if a patient goes or a user goes and sees their PCP or they get a flu shot or other things like that where that's like an extra incentive for them or an extra little boost in their score, so that way they're actually going to go see their doctors more often and maybe kind of push them so that way they can have a conversation more with their PCP and others?
Yeah,
the flu shot incentive is a good one.
Mm-hmm.
What was that, Sharice? I'm sorry.
I said the flu shot incentive is a good one.
Yeah, and that does work because a lot of insurance companies are doing that now. Your annual checkups, your flu shots, and it works. I mean, you are paying somebody to go do something, giving somebody a reward. So yeah, we'll definitely do things like that in terms of not only that, but I mean, just kind of go on down the list. There's a lot of things you can do to spur people into action and be proactive about it. And the thing is, this is all open source to an extent where if anybody has ideas, just propose them and this community will adopt them. That's the idea of, you have all these closed off systems, these closed off EHRs that they don't take input very highly from the community. It's not like they ask a bunch of physicians to come down and say, sit down, hey, how can we make your life easier? No, they go to the CEO and the CFO and say, hey, how can we make you more money? And that's not what we're trying to do. So we're trying to create this open source environment where the patients can come to the table, the physicians can come to the table, the caregivers come on here, and we can all collaborate together to build something that works for everybody. And I had a good conversation today with a physician out of Texas, Alan Hand. Matthew, you and him would get along well. Had good conversations. And I was talking about this health operating system idea to him, and he absolutely loved it. And he's been past 20 years wanting to completely revamp the way an EHR is, the way it functions. And he says it's not a tool it's not a tool to help him out. It's a tool to hinder him as of right now. It slows him down. It causes frustration. And as technology, we have really cool consumer technology that it works like magic sometimes. And that is not in healthcare. It's not in medicine. And Matthew, you mentioned having that Apple moment, just like, whoa, this is cool. That refreshing feeling. And that's what we need to bring to this health operating system, kind of getting off on topic there. But we were also talking about the health scoring system and the treatment side of medicine. And a lot of times he said he could diagnose a patient based on just visually, verbally, just going through things. You don't necessarily need to run all these tests and do all these imaging tests, but it really comes down to the treatment. How are we going to treat this patient? And how are we going to use the data that we have to make good decisions? And that's one thing. He has all these different vendors come and bring them all kind of analytical suites of tools that just don't help. It's just information overload. And he says still he has yet to find something that represents a patient's health in terms of just, this is it. This is what you need to know. This is what's important today over the course of the past week. And that's, he loved the idea of the health score and just everything we're talking about now. So physicians do see this. I think there's a big need, and I would love just to start open sourcing this more to get everybody, to get their input, because everybody has unique experiences and backgrounds that you can bring to the table and help build this. So in the bill, I guess we can talk about this now. We do have an open source project coming online for the health score. I think we mentioned that 2 weeks ago too, but it's just kind of what we're talking about now, the health score, bringing in physicians, bringing in other researchers, data scientists to come together and work on these algorithms, figure out what's working and what doesn't work. And also we have another open source project too for almost like a personal health record, but thinking more of it as almost a data hub where you can take all these different devices, all these different data sources and bring it together and normalize it into one area. So Bill, we can talk about that later or now if you want to, or if anybody else has anything.
Yeah, well, just briefly. So the open source, the health score open source initiative, it's something that we want to basically use, but have other people use, and which means we want to make it open source so that we get contribution from everybody, including users. Any user can just go and give us the idea what is the easiest way and the best way for them to look at their health, so maybe is it a number, a score, is it a number between 1 and 10, is it a graph, etc. But for physicians also, it would be interesting, like talking to you, Matthew, right now, is what contributes to health, and also what are some of the metrics or the behaviors that contribute the most? Can I maybe weight them, maybe make it more personalized, so that for some people, sleep is not as important as steps because of their condition, but that can change throughout time. So all these different ways of thinking about a health score or a health. I'm trying to find another word than score, because it doesn't have to be numerical. It can be something that represents your health, but easy to see from perspective of a user, and also easy to understand from perspective of physician. But this open source will include developers, patients, physicians. Will try to make something and then distribute it, and people can use it in their apps, and maybe physicians and hospitals can use it. So
how do you, when you say you're just going to put it out, how are you going to market that to the physicians out there?
So as an open source always starts from the bottom up. So it's an engineering or development project. People use it or work on it, and then eventually the more organic way of doing an open source project is engineers or developers will come, like it, then start using it in their apps. And those apps are probably targeted to physicians, and that's how physicians will learn about it. But you're right, now that we want to get also physicians involved, we will have to do some marketing there and bring at least some influencers that would help, and then maybe talk a little bit about it around.
One suggestion I have for that is, so I attended a few months, so I retired from clinical practice about a year ago, mostly to dive into some other areas, including artificial intelligence, the ethics of AI, some of the things you're talking about. Not quite sure what my direction is, but I went to MIT and I got a certificate in strategy and innovation, so flying back and forth to MIT. And one of their courses there was on innovation ecosystems. And they spent a fair amount of time. And so this is, top floor at their MIT Innovation Center, some really brilliant people. And they talked about different ways to innovate within a given ecosystem. And one of the subsets of that was hackathons, and how culturally hackathons in, say, the Silicon Valley group is the 48 hours all crunched together doing one little project, but that in most businesses, you can't necessarily access that. You're not going to get 50 physicians doing a 48-hour hackathon who are 50 years old. They'd all just die on the floor by the end of it. But what you could do is, when you're really ready to kick off that open source effort and you've got some core stuff, is you could do a mini hackathon around maybe one of these family practice conferences or something like that, if you had an advocate or a thought leader from there. So you could actually do something for 8 hours or something to get a critical mass of physicians involved. So there might be something you could do with a hackathon that's inexpensive around a conference. It would just be a conference room for 8 hours where you present it. So it's just an idea, just putting together, because I thought at MIT, I said, I'm going back to my old clinic to do some presentations on algorithms for them. And I just know that physicians, would be very valuable to sit and talk to you guys, and you'd get some value out of them, which is part of the reason I like attending this, is because I had a box, I want to learn about blockchain this year. And so when I found you guys, I said, I'm going to be able to check out that box because I'm learning a lot. So, but think about a hackathon centered around physicians. The other thing is behavioral health people are generally psychologists. So most of these big groups, they have physicians, but they also have psychologists. and they call them behavioral health. It's usually a group of mixture of psychologists and psychiatrists. So that's another target market for you, because most behavioral health people are still going to want them to have a healthy lifestyle. So apart from obesity medicine, you might target behavioral health groups or departments within these large organizations. How are you sleeping? Are you walking enough? How do you have a lot of activity? That's helpful for behavioral health specialists to know, I think.
No, that's a good idea. I mean, hackathons, short hackathons, but there's also, I think a lot of companies do sometimes organize contests, or, like, I think there are some websites like Kaggle where for artificial intelligence, you just provide data or provide the software, and then you create a competition around it that can last more than few hours, and you let people go and play with your tools or with your software, and then come up with cool new ideas. I think it's a good idea. Do you believe that for physicians, giving this, organizing these hackathons would not only bring them for a short period of time, but maybe get them interested in helping with this? Like, my question is, I know I'm a developer, an engineer, so I know that a lot of us have side projects. We like working on things on the side. Do you think physicians have the time and maybe the will, to do something like this on the side?
If you go to, are any of you in Doximity, familiar with Doximity, the website Doximity? So there's a fairly large percentage, possibly because of EHR, dissatisfaction with EHRs. And there's a group of physicians that are going to be retiring early. And it's probably a 10, 15%, it's probably a pretty large chunk, that may want to step down or back off on hours. But they still have all this talent. I'm not talking about 75-year-old physicians. I'm talking about mid-career physicians looking for a change. And that's probably a group that would be willing to put in their own time on stuff like this. And their experience, they might be at the peak of their career, but they're trying to step off from these. We're some of these guys, I was working 50 patients a day, 12-hour shifts, 2 of those in a row. And that's hard to sustain that for 10 or 15 years. That's tough. I think there's definitely a group of physicians mid to late career that want to back away from clinical practice, and that would be very kind of, I think, interested in a lot of the stuff that you're doing, because they still want to use their talent, but they don't necessarily want to be just a high volume patient person anymore.
I would agree with that. As someone who works in interoperability, formerly at a open source company, the amount of doctors I've spoken to over the years, even as of recent, having side projects, even going into blockchain, trying to come up with their own software. And even recently, I posted on Twitter yesterday, I was looking for an endocrinologist, and the amount of endos that actually are all concierge now. None of them took insurance anymore. None of them wanted to deal with it. And it was interesting because, like, some of the solutions I was looking for, a lot of these doctors have started up a subscription service almost. And so it's really interesting seeing how everyone's transitioning with, whether it's EHR, insurance, and everything involved with the current healthcare climate and everything, how that's all shifting. So a lot of them are looking at new ways of revenue, not having to deal with the hassle of insurance or the EHR and other things like that. So I think you'll definitely find quite a few that are willing to do it. Like I said, I know some personally that are into blockchain already, trying to do their own thing, in all different ways. So I think you do very good with that. And my question would be, is like, when you guys are talking open source, are you talking like open source Mozilla public license 1.1 type of open source, or are you just talking about more of a community effort of getting input?
Both.
Okay.
We've been going back and forth with the actual open source license. We settled on MIT license, either MIT or Apache. I mean, it's relatively the same. But yeah, open is open. But also, that does nothing unless you have the community around that.
Sure.
I think first and foremost, we've got to have the community. Have that community of just openness and transparency where people can bring their ideas and we can talk about ideas. And on that note, we have a forum. It's forum.citizenhealth.io. And we kind of let it die off the past couple months, but I would love to fire that back up with conversations like this. Let me share that with everybody.
No, I think that would be good. Like I said, since I came from one of the open source companies, and if it's an integration engine, you can kind of figure out which one that was. That was that's all in healthcare, that everyone used it. It's a huge user base of people within that space, and everyone was willing to input. And it was very interesting the way that worked. So I got very firsthand experience in that open source community, and it is going like, I'm sure Nabil knows, it's like going on Stacked Overflow and talking to all the people over there. And there's a lot of open source forums and everything, but the cool thing about going open source is you're going to get, beat up a little bit for a little bit, and you'll get beat up for a while. But then what it does is that community is also going to embrace you too. And the reason why they're beating you up is trying to help you and do better. So it can really pay dividends years and years and years from now. And I saw that firsthand.
Yeah, I think that's the only way we can build something like what we're talking about with citizen health in general. You can't have that closed off mentality. It's not going to succeed. Sure, the capitalistic structure we've had past 200 years, it's worked, but I think now with the internet and decentralized technologies and blockchains and stuff like that the model of collaboration it's here to stay. It's only growing. So having that model of scaling ideas, I love it. Just iterating on ideas, and you take, not necessarily stealing somebody's idea, but you're putting it out there for everybody to work on and get feedback on. So it's just a refining process that's amazing to watch.
Brennan, so here's so in terms of your business model short term, next 6 months to a year. So for example, I'm going to a GeekWire summit next week in Seattle. And it's GeekWire, as you guys know, it's 2-day summit. First day, it's all these bigwigs. The CEO of Boeing is going to talk, and the senior vice president of Microsoft, and all those folks. But the second day, they have a health summit, and it's simply just a health track of all different people in AI. There may be a blockchain person there. It's all about data and health. And there's going to be a networking opportunity there. Sometimes I go to these things just to learn and listen, but sometimes I go there to network. What are you guys looking for in the near term, the next 6 or 8 months? Are you looking for people to beta test your app? Are you looking for investors? Are you looking for ideas on how to get physicians to use this? What is your actual need from kind of the traditional healthcare community?
Yes.
It's because if I'm speaking to someone and I'm going to say, oh yeah, there's this neat company, I talk to sometimes, and what do you want me to say to them? Just if I can say something nice about you.
Yeah, well, definitely. Just with any startup, we do need capital. So we do have a crowdfund going on. We'll be having an additional Regulation D offering alongside that. So we are looking for physician-only investors. And this is a model we're looking at of having physician-only investors. They would in turn be almost a node in our network, a trusted node, a validating entity in our network of this health operating system that we've been talking about. So yeah, capital for sure. And also with Metaplex, we have a scheduled launch date of January 1st for that. And that's going to start off, I say fairly basic, but it's going to start off complete in terms of the ability for anybody that has a service, a healthcare service they want to sell, such as a surgery center with a bundled surgery, or imaging facility selling MRIs, or a primary care physician want to sell a 30-day supply of their services in terms of a subscription. And also the people that could potentially would want to buy those solutions. So a patient with a high deductible, a self-funded employer. So really looking for both sides of that marketplace, because it's that chicken and egg problem. You have to have the supply there for
critical mass to get the data to improve your system.
Yeah, so really looking for any medical entity. We're going to start with surgery centers, because a lot of these surgery centers out there, they're ditching insurance. They're realizing that they can make more money and have less headache by just offering their surgeries with a direct price, a direct contract with self-funded employers. And we have a handful of them coming on board now, ready to start. And also imaging centers, the MRIs and x-rays and just everything that comes with that. And then start going on to your endocrinologist, your specialist, your primary care physicians, the ones that are going away from insurance. That's the ones we need to attract. Not necessarily hospitals yet. They don't fit in our system yet. Eventually they might start coming over on board, but their incentives are not aligned with what we're trying to do. And and also the beta testers. So you're looking at the physicians as well with this health operating system that we will be putting together. Probably start that in middle of 2019, first quarter, second quarter. But having physicians wanting to beta test that, and not necessarily beta test it when we have it, but help us build it, because that's what we're going to need. Some people that are committed to fixing healthcare, and ones that have a good background on technology and how to build it with, not necessarily the coding aspect, but ones that want to see it change, want to help us change it, and also use it once we did change it. So it's kind of all the above there.
So a suggestion for you for the surgery centers is, so on your Medit health score, if that gets cleaned up, especially for bariatric surgeons, they want there to be a low complication rate. And one of the ways you get a low complication rate is you have patients active before surgery and you have patients active after surgery.
Right.
It works well, but if you have better behavior change. And so there would be a way to say, look, if you use this health score and these parameters, and we'll get them worked in with a Fitbit, perhaps you can give them a discount on their surgery if they do these things before the surgery and do these things after. So that would be a way to potentially market towards the subset. So gallbladder surgery, probably not much there for this. But bariatric surgery, there's a big component of behavioral changes. And so you'd want to talk to a bariatric surgeons, even in your community. Most of them would have some ideas on that. But that might be something that would just be short term. I think they would like to kind of look into that a little bit. And a lot of those surgeries aren't covered by insurance. A lot of people just want to get them. They don't want to wait the 6 months or a year. So everyone can benefit from that.
I'd like to add a little bit on what Anthony said as far as specialists now that are looking at direct care options or opting out, if you will, of insurance. Most of your hospital-based specialists, that's not going to be a reality anytime soon, but endocrinology, certainly dermatology. I've even got we got a handful of podiatrists that are doing direct pay right now. And I know that's maybe second level, but I think anybody that's not hospital-based is going to give it a serious look. And especially once CMS does away with, or at least institutes site-neutral payment specifically for procedures, you're going to find a whole new crop, if you will, of physicians are going to find themselves without an owner and are going to be looking for some options. I think hospitals are going to start shedding practices once that reimbursement differential goes away.
Can I make a prediction here? Document this. I said it a long time ago. I think hospitals in the future, not near term, but they will turn into fancy landlords. They will have the building, they will have the equipment, they'll have the rooms, but then physicians will just lease those rooms, that equipment, come and go. I'm gonna see that happening. Like the actual hospital.
Right now, they're kind of getting it for the only thing the physicians are having to pay is, well, really not much. They get their technical fee or their professional fee, and the hospital gets a technical fee. So I agree. I think it's a brilliant prediction.
Yeah, they're absolutely doing that with other businesses right now too. I know I forget the company name, because didn't that company just get in trouble that did it? Where you can actually lease these little spots, just like I know a friend that's a stylist, and they have this one area where it's just a completely blank room with all these little stations, and she just rents one chair. So it's not like renting an entire salon or whatever. It's its own thing. It's not a particular salon or anything like that. It's just her little spot in this little 10 by 10 space. and that's it. And that's her only thing. She's not responsible for anything else or paying the salon or anything else like that. It's a very interesting thing. So I'm sure you're going to see more and more of that.
Well, it's like WeWork, it's the
I think that's what it is. Maybe is it WeWork, right?
Yeah, I mean, they're the biggest company doing this, and they're just taking off. But it's like this on-demand economy. You got Airbnb, Uber. You're moving to that model that the traditional hospital, as we know it, doesn't need to exist in the way it does. People don't need to flock to a hospital. A lot of this care can be done at home. So that just changes up the dynamic of having that huge, expensive hospital.
Yeah, I can't.
The hospital has regulatory issues too. Like it's almost like you can't just hang a license there. Like if someone wants to rent a room from a hospital, the credentialing thing comes into play, right, and you're working under the hospital's license. So you can't just rent a room. You gotta, there's more things that come into play. I have a client right now. I think I was telling Anthony about him yesterday. He's in New Jersey. And one thing that he started doing was renting space to psychiatrists. His different, I call them suites. And he got into a little bit of trouble with the state because they were like, well, no, if they're in there, they're under your license. So you can't just do that. It's different. Like if WeWork, everybody has their own thing, so to speak. But hospitals don't have that leisure, that luxury.
Yeah, there's going to have to be some regulations that need to be changed. There's plenty of regulations that need to be changed.
Right.
It'll happen over time.
Right.
One thing just earlier that you said, and just something for you guys to think about, you were talking about earlier how there were very few studies done where if you paid patients to walk, they would walk, but as soon as that money dried up, they stopped walking. In essence, one thing to consider, I don't know if you guys have looked into ABA or applied behavioral analysis. That's the study behind behavior modification. And the reason why I know anything about it is because my wife's board certified in it. So she's taught me all that stuff, or I've helped her study for all those exams and everything. There's actually a method of getting people to actually change their behaviors. And yeah, you can't just keep rewarding them every step of the way. There's actually a whole process to it and a scientific method to do it. Funny enough, we did it to potty train my daughter, and it worked beautifully. But it really works. Sharice and I have discussed this method multiple times and everything. So it's something to look into, and on the side I can explain it to you guys in more detail. But finding someone that specializes in ABA can explain it, but that's their entire education and practice is actually behavior modification and the different ways of doing it.
Yeah, I need some tips on that potty training side.
So I'll give you a very high level version of what it is, but basically, so my daughter, she's now 3. She wanted to start potty training early. She's about 1.5, and she's like me. She is super stubborn. So her thing is she just wanted to be out of diapers, but she refused to go on the toilet. And so I'm sitting here fighting with her because she doesn't want to go on the toilet, but she doesn't want to be in diapers. So then she, wets herself, gets very upset, her self-confidence, everything. And it's a constant battle back and forth of my stubbornness, her stubbornness, and my wife's rolling her eyes at me. So what ended up happening is we found something that would motivate her. And it's for her, it ended up being a mini M&M. Handed her a mini M&M, and you saw her jump right up onto that toilet. And what happened is every time she did it, we rewarded. Obviously, you give verbal praise and everything, like she won the World Series kind of thing, which is always great. And then you add the mini M&M every time she does it. But what you don't want to happen is her to be in high school after second period calling me, "Hey, Dad, I just took a deuce. I need you to bring me a pack of M&Ms," right? You don't want that to happen. So what ABA actually gets into it is there's a certain method of it. So you actually give it to her. You do high praise, high rewards early and often. So, there's the M&M, mini M&M. Every time she had that feeling, we gave it to her. We rewarded her, verbal praise and everything else. After the first few times of doing that over a few days, however it goes, you start doing it every other time. And then you do that for a bit, then every other time, every once in a while. And all of a sudden, the desired behavior she's doing on her own without expecting the reward anymore, because she's realizing, oh, there's a self-confidence. She's doing the desired behavior. It's something we both know she wanted to do. She just had to get her selfish thing first, and then that's how we did it. And that's actually one of the methods of ABA of doing it. Now she doesn't expect me to give her a mini M&M anymore. So that's one of the very many methods of ABA that actually gets that done. And that's just a quick way of doing it in that way. So if you're looking at rewards, obviously you want to do the signing up, you get a bunch of bonus rewards, right? That's that early often, as they get their first couple of steps in or whatever it is, you want to reward them early and often. And then maybe as they grow and grow and grow, you do a tiered structure where they have like credit card reward system, where the higher the level, the more input they do, they have to put in a little bit more work to obtain it. But then all of a sudden that reward is their health and getting better and everything else. And then once they reach those levels, it gets harder and harder to obtain. But there's some great rewards if they keep working at it. So just something to keep in mind. Obviously, the crypto and everything getting with that is also a bonus with that. But just something to keep in mind when working on the reward program. So just that quick little input there for you.
Good point. I'm going to go grab some M&Ms on the way home. Did you happen to get a chance to look at that octalysis framework that I sent you?
So I was reviewing it. So yeah, it was actually very cool. I actually gave it to my buddy that I'm doing a project with Miss Charisse over there. We're all involved in a cool little project on our own that I mentioned last time. So yeah, we were reviewing it. So thank you very much for that.
Yeah, no problem. Yeah, it's a good thing to keep going back to every time you have. It's like, how can I trigger this desire, this outcome?
Yeah.
How can you motivate that? So it's a good resource.
Yeah.
Highly recommend the book, but once again, you can sum it all up in just those couple posts.
One other thing, Nabel, I thought about on your on the app is you were talking about you need confirmation to get your Medit credit. When you say you want to join LinkedIn and you fill out a profile and it says 75% filled out, 85, 90, 100% filled out. In a sense, you have your profile screen, which is not confirmed, but say fully filled out. When you go to a doctor within your system, who I would assume has their own little code or something special to them, when they confirm it, when they confirm your weight is 210 pounds on that day, then that becomes 100% confirmed profile. And that would be a way, there's certain things that you would want people not to cheat on, but it would be a way to kind of confirm, yeah, they've got 100% profile that's not confirmed is, maybe better to have a 70% profile that has been confirmed by one of your physicians. And that can be very simple, just handing them your app and can you put in your little bit code or whatever it is for the physicians. So it's just a thought how you can include some of those simple profile scores. And it makes it harder for people to cheat, especially if weight loss was one of your things you didn't want people to cheat at, then that would be weigh-ins.
Get rewarded with validation.
Basically. And I think that people that are going to use this, they're going to be pretty bright. They're this, at least initially, those first movers, they're going to have to kind of want to do this. They're going to have to feel comfortable with apps and that type of thing. So it's perfectly legitimate to just explain that to them, that this will count if it's confirmed, but we can't let it count because that's our model, is we want this to be verified data. And most doctors would feel pretty comfortable, even if they were in an urgent care center. The other place that this might be a little more tricky, but fire departments will always take blood pressure. People can go by a fire department today and get a blood pressure. Mm-hmm. And, that is a way to get a confirmed blood pressure by an experienced person. And there'd be little room for cheating there. So.
Yeah, you could geotag that too. You can have that reading there and you could say, all right, well, I'm at this location. This is a known location for a firehouse. So adding in an extra step of validation there.
Anyway, something to fool around with for that.
And also, Anthony, I'm going to chime in on that, and then we can call it a night because we've got about an hour here. But the corporate wellness programs, we haven't actively looked at them, but we do have an advisor on our team. He's an employer benefits consultant. He's talked to quite a few of them about this, and they're all for it in terms of employee engagement, health and wellness engagement. And there's quite a few apps out there that there's rewards for getting your flu shot and checkup and stuff like that. And a couple of them are starting to incorporate wearable data. Matter of fact, I was at a conference last week. It was a self-insured conference. And there was one app there. They were absolutely talking about loving it. And I went through a demo and I'm thinking, this is terrible. Like, you should scrap that screen, do it over. It's too many touches. Anyway, they were going on, and they only worked with Apple Watch. And there was no motivation there. It just showed your score. It wasn't very good, but they said they had a couple hundred employers using that. Not sure if that's true, but if that is true, then we have a great product because having the ability to start incorporating a lot of different wearables, bring your own device, so to speak, and having that score and having leaderboards is something we're also going to look at. Have just leaderboards in terms of where are you at on this score within your organization, and where organizations can compete against each other, and also just at a hospital, I'm thinking nurses on each floor, like OB and intensive care and neonatal stuff like that. The different nurses, I guess, the different floors can compete against other ones in terms of steps throughout the day. Stuff like that to make it fun in an organization, make health fun. So yeah, there's a lot of things we can do to definitely keep them engaged. And I think that's the big part that's missing in these corporate wellness programs is the engagement and also the return on an investment, because how are you going to measure a return on your investment? There's really no way to do that now. But we have been working on something. We shelved it, but we had this big grand plan about it last year with social impact bonds and looking how social impact investors can start investing into these corporate wellness programs or just employers in general, captives, if you're familiar with captives. I'm looking at some type of structure where you can start getting a lot of self-funded employers to come together and almost like collateralized debt obligations. Need to come up with a better term, but collateralized health obligation. You could mint something like that and have these social impact investors invest in the health of your employees. So there's a lot of things that we've been working at, and that's a big idea if we follow that through. But we have to have this health score where it needs to be and have Metaplex where it needs to be before that can even be released. But to answer your question in a short form.
It's not only employee benefit advisors. We have some DPC groups that are very interested in taking it to some of their corporate employer folks, and I'm talking small employers, 200 people. But yeah, the exposure's getting out there.
Yeah, and I'll tell just that one story. Connor Gunn is the advisor I was referring. He said one of his one of his clients, their wellness program consisted of a end of the week meeting where everybody brought their Fitbits and they literally wrote the number of steps up on a whiteboard, and that was their leaderboard, and that was their wellness program. So it's a very rudimentary, and I think there's a lot of room for growth in that, especially with all the newer devices coming out and everybody jumping up and down about the Apple Watch. But there's a good opportunity for what we have, and I think more and more employers are starting to use that. Now that's low-hanging fruit. We could go that direction, and we will go that direction with some of these employers to test it out and just see if it gains traction. And that's a near short-term instant or path of revenue for us going that direction. So really just depends how these next few months work out. If we can find some employers that are ready to possibly pay up front, start testing it out, then we'll go that direction.
Very cool. Yeah, I was just curious if you guys had been going in that direction, and absolutely. Like I said, having been at one of a big and previous company, I used MD Live that way, and MD Live was just slightly discounted, and I'd never heard of it, which was funny being in health IT. This is like 5-6 years ago. And as soon as I use them, like, this is amazing. I have no reason to, have to bother with urgent care in a lot of situations. And I've used it ever since. The only thing they don't have is on-demand endocrinologist, which is what I'm still looking for. So I found some interesting things in that research, but that's a whole other subject. So.
All right. Well, everyone, if nobody else has anything that you want to talk about, we can call it a night. Anybody else? Everybody good?
Good.
Awesome. Well, thank you all for your time. I know it's very valuable. Time is always precious, so I appreciate it.
Enjoyed it, everybody, as always.
Thanks,
Thank you.
everybody.
Take care.
Have a good one.
Every 2 weeks? Is it roughly every 2 weeks usually?
Yes, sir.
Every 2 weeks, yeah.
All right, great.
Every
All
2
right,
weeks.
thank you so much. Bye-bye.
Bye.
Okay. Bye-bye.
All right. Well, I know y'all said y'all were going to, well, Thought and Bill's going to stay on.
Oh, do you want to stop recording?